Today we'll be wrapping up our discussion of Chapter 18, the heart, in our Anatomy and Physiology textbook. Last time we talked about the electrical events of the heart cycle and some arrhythmias, some abnormal heart cycles or electrical activity. Now we're going to talk about stroke volume and heart rate and how they impact cardiac output. Okay, look at this crazy diagram. If we focus on the middle part, this middle graph, it's showing us pressures. Pressure is the force per unit area on the wall of some container in which the pressure lies. In this case, it's blood applying pressure to the walls of the various chambers of the heart, or here's the aorta. And this green line, the blue line, represents the left ventricle, and the pink line or purple line represents the left atrium. We're watching the progress of a heart cycle, or part of two heart cycles, if you will. And you can see the background is kind of drawn in light blue. All of a sudden it switches to tan and then back to blue again. So the blue parts, right? Time is going by on the x-axis, and the blue parts represents the resting phase of the heart cycle. The heart contracts, and then it relaxes, contracts, and then relaxes. So the period of time when the heart is relaxed is called diastole. It's a word of German origin, so we say that we pronounce the E at the end, diastole. When the heart contracts, this tan area, the ventricle I should say, that's called systole. Systole. And then of course we return to diastole. We see another part of the resting phase of the next heart cycle here in blue. So what's happening in these regions? Okay, so during resting, the heart is filling with blood. Let's look down here at this graph too at the same time. This is the volume in the left ventricle. During diastole, the ventricle is filling with blood. It's returning to the heart from the veins. And so the heart's getting fuller and fuller. The volume is increasing until finally it starts to contract. Well, when the ventricle starts to contract, the first thing that happens is blood tries to go right back up into the atrium, but it can't. Let me just say that blood always moves from higher pressure to lower pressure. That's what makes blood flow or move. So the ventricle starts to raise its pressure by contracting the pressure inside the chamber, and when the pressure in the ventricle exceeds that in the atrium, passing this pink line, blood tries to go right back up into the atrium, but it can't because the AV valve slaps shut, and it makes this little zigzag is supposed to represent a sound wave. It's an impact like clapping your hands, only clapping them underwater, if you will. So right here, where these two lines cross, that's the closing of the atrioventricular valve. Now, the pressure in the aorta is still much, much higher. This is it right here, and this green line is the pressure in the aorta, right? Pressure on the y-axis. It's much higher. We're still down here, and so the semilunar valve is also closed because the pressure is higher. The blood's trying to go back into the ventricle, but it can't because the semilunar valve is closed. Then the ventricle continues to raise its pressure, only when the ventricle pressure is higher than the aortic pressure, right? When the blue line crosses the green line. Now there's more pressure in the ventricle than the aorta, and then blood flows from high to low pressure, from high pressure in the ventricle out into the aorta where it's lower pressure. So all the while that this blue line is higher than the green line, we are ejecting blood into the aorta. So the semilunar valve opens right as these lines cross, and blood is being ejected all the while. And we can see that. Look at the volume of the ventricle. It's dropping precipitously because we're ejecting blood. And then finally, the ventricle relaxes. The pressure in the ventricle starts to drop. As soon as the ventricle pressure is lower than the aortic pressure, then blood tries to go right back down into the ventricle, but it can't because the semilunar valve slaps shut, making a second sound. So if we're listening to this heart cycle with With the stethoscope, auscultation that's called, we'll hear one sound when the AV valve closes, second sound when the semilunar valves close. Lumped up, lumped up. Okay, so there's something peculiar going on here that we haven't really isolated or focused on. During this period of time, when the ventricle is contracting and the pressure is rising, but it has not reached aortic pressure, all the valves in the heart are closed. And but the heart is still doing work, it's still contracting. That's called, this period of time, defined by this darker tan box, is called isovolumetric contraction. Iso just means same, volume contraction. Right? We're contracting, but we're not getting any blood out yet. And you can see right here the volume is staying constant. And then finally, when the semilunar valve opens right at this point, boom, blood starts ejecting out. We see the volume dropping as we continue to raise the ventricle pressure. And then finally, when the semilunar, the aortic valve closes, then look what happens. The pressure in the ventricle is still much higher than in the atrium, right? So the AV valve is still closed. All the valves are closed again, and the pressure is dropping. All during this period of time, the ventricle volume is constant, and we call that isovolumetric relaxation. I didn't write it on there, but you should know that. That's isovolumetric relaxation. And then finally, when the ventricle pressure is below the atrial pressure, then the AV valve opens and blood comes splashing down into the ventricle from the atrium where blood has been accumulating and fills it back up again. So all during diastole, we're filling up. And there's a slight increase in pressure. We're actually going to stretch the walls. We're actually going to stretch the walls of the ventricle as the blood is filling from up in the atria. What's the significance of the atrial pressure being higher? That's why blood is flowing from the atria into the ventricle. It flows from higher pressure to lower. Not much higher, but it doesn't take much to push that blood through that wide open, gaping AV valve, the mitral valve. So that's the story of this diagram. Incidentally, the EKG, electrocardiogram, is shown at the top for comparison. I'd like to take a look at that. When the atria contract, it's this little hump right here, and it'll shoot a little bit of volume down into the ventricle. It creates the P wave of the electrocardiogram, the wave of depolarization of the ventricles. Then we wait for the AV valve to conduct the action potential down into the ventricles. Then we have ventricular contraction begins with a wave of depolarization, the QRS complex. That's lightning fast. But the ventricles stay contracted for a long, long time because of the slow calcium channels. And we have the plateau phase of the contraction, and then finally, when the ventricles repolarize, they've produced the T wave, and the T wave corresponds to the relaxation of the ventricle and the dropping of pressure. So there's all the parts of this diagram fully explained. So remember, time passing on the x-axis, all the time that passes while we're in the blue is diastole, all the time passing in the tan is systole, and so forth. So study that diagram. It's worth knowing. I think it's important to know, actually, to understand what's going on and be able to say, when do the valves open, AV valve open, or I'm sorry, AV valve close, semilunar valve opens, semilunar valve close, AV valve opens again here. So we should be able to identify those events on this diagram. Okay, one last thing. At the end of diastole, end diastolic volume, that's what that's called. How much blood is in the ventricle? It's the end diastolic volume, right before a contraction. Then the ventricles contract and eject blood. As you can see, we don't eject all the blood. There's still around 50 mils of blood left in this example, left in the ventricle, and then we start filling it up again. So the difference between those two volumes, end diastolic volume minus end systolic volume, is what we call the stroke volume. It's the amount of blood that was pumped out in the beat, or in every beat. The stroke volume, mils per stroke, mils per beat of blood being ejected. All right, so I'd like to now talk about cardiac output. Cardiac output is a way of assessing the performance of the heart, and therefore it's actually created by the demands of the body for oxygen and blood flow. Cardiac output is the liters per minute of blood pumped by the heart. You add together all the stroke volumes over an entire minute, you get cardiac output. How do we express that? It's all the stroke volumes in every heartbeat. So heart rate times stroke volume equals cardiac output. So if the heart rate is 72 beats per minute, which is pretty typical resting heart rate, times 70 mils of blood, just like we saw in the previous example, per beat, you multiply this together and you get 5 liters per minute. That's a good value to know by heart. That's the typical resting heart rate textbook value for an average person, 5 liters per minute of blood. Incidentally, you have 5 liters of blood, so every bit of your blood is circulating through the cardiovascular system each minute. Now, this is a highly variable number. Right? You can think of times when there's a lot more action happening in your heart, a lot more blood is being delivered. When you exercise, you have to deliver a lot more blood to your exercising muscles. So what we're going to do is try to examine, in order to understand all the things that affect cardiac output, we're going to examine all the things that affect stroke volume and all the things that affect heart rate, and then we'll pretty much have a handle on all the variables that can affect cardiac output. So for example, when you exercise, your cardiac output may rise to as much as 35 liters per minute. Right, at rest is 5, so if we subtract 5 from 35, our cardiac reserve is 30 liters per minute. That's pretty good, pretty decent, how much we can increase it. That means you can really do a lot of activity above what you do at rest. If your heart isn't well and you don't have that reserve, you can't do activity. You are only going to rest, and we'll talk about it at the very, very end of the chapter. Okay, so first off, what are the things that affect stroke volume? First of all, there's a kind of an almost magical property of the heart such that the end diastolic volume determines, in large part, the stroke volume. The end diastolic volume, what affects that? The filling time. How long are we going to wait for the heart to fill up? Because blood just keeps coming back to the heart through the veins. That's called venous return. And also the venous pressure that's pushing the blood into the ventricle. And systolic volume, how much blood have we left behind after the beat, right? Because stroke volume is end diastolic volume minus end systolic volume. And that depends on how much pressure there are in the arteries that the heart has to overcome to pump blood out, and the force of contraction. The harder the heart contracts, the more of blood's going to be ejected, and therefore less is going to be left behind in the heart. So stroke volume is end diastolic volume minus end systolic volume. We're going to take a look at what affect, a little bit closer at the things that affect those two. So here's the 3 things that affect end diastolic volume and end systolic volume, and then we'll really have a handle on preload, or on stroke volume. Preload, as I was just starting to say a minute ago, is the amount of blood returning to the heart during diastole. Preload is the exact same thing. It's a synonym of end diastolic volume. It's also synonymous with venous return. I like venous return because it explains what's happening. Blood is returning to the ventricle during diastole. How much? A specific volume. That's what we call venous return, that volume which returns to the ventricle. Here's the magic thing I was talking about. The construction of the muscle cells in the heart, the cardiomyocytes, is such that if you stretch them by filling them with more blood before a beat, they'll contract more vigorously. The more you stretch the heart wall, the ventricle wall, during diastole, the more cross bridges will form, and the more firmly it will contract. Isn't that amazing? So if we return more blood to the heart, it'll just pump away that extra blood without any information, without any regulatory system involved, just mechanical design of the heart itself. That's called the Frank-Starling law of the heart. So if we do anything by way of exercise that helps return more blood to the heart will just pump that additional blood out, and right there that'll jack up cardiac output significantly. It's also something that keeps the 2 heart pumps synchronized. They're separate from each other. But if one side of the heart pumps a larger volume of blood out, it's going to come right around to the other side, stretch that heart wall a little bit more, and then that heart will pump that extra volume out. So they'll just keep the 2 hearts doing the same volume all the time. So what are the things that affect venous return? Right? If we're saying that venous return, preload, is a big factor in stroke volume, let's look at it. During exercise, there's a couple of things that happen that increase venous return. One is muscle pumping. there's veins deep down in your muscles, and every time you contract the muscles, it wrings out the blood from those veins and pushes it back to the heart. And the reason it pushes it back to the heart instead of just out of the muscle randomly is because there's valves, there's one-way valves in the veins, so the blood can never go backwards in veins. It can only go towards the heart. Once the blood goes from the blood capillaries into the veins, then it always moves towards the heart. So muscle pumping, the more rhythmically we contract our muscles and the more muscles of the body that are working, the greater the venous return because of muscle pumping. Okay, what else happens during exercise? Lower resistance. When tissues exercise, we kind of have a chicken and egg problem here. When tissues have increased metabolic activity, when you exercise the muscles, they vasodilate, so that more blood can get into those working muscles and deliver more oxygen. And we'll have to talk about a mechanism of that in chapter 19. But they dilate, and if they dilate, they open up the vessels to a larger diameter. It's easier for the blood to flow through, and therefore it flows right back to the heart, so that increases venous return. It's called reduced resistance. That's what we say when we vasodilate. Easier for the blood to get through. During exercise, the heart rate increases, which reduces filling time, and that in itself actually does lower stroke volume, lower end diastolic volume, I should say, but increasing heart rate overall, because there's more strokes happening per minute, increases cardiac output anyway, but that's sort of an aside. All right, venous constriction. The veins are very large diameter vessels compared to the arteries are supramuscular, narrow diameter vessels, relatively speaking. The veins are huge. And so they have a lot of volume in there passing through. At any one time, almost 2/3 of the blood is in the veins on its way through. So during exercise, the sympathetic nervous system turns on and causes vasoconstriction, as you know. And when it happens in the veins, it takes that huge volume of blood and starts pushing it back towards the heart because there's not as much room. We contract that smooth muscle. That is a huge increase in venous return and therefore cardiac output, because stroke volume is going to jump right up. Frank Starling law. Finally, the respiratory pump. The way you draw air into your lungs during breathing is to lower the pressure in the thorax, and air moves into your body from higher pressure outside to lower pressure inside. Right? So you create the pressure difference by creating essentially a vacuum in your thorax. Well, that same drop in pressure in your thorax draws blood. Blood flows from higher to lower pressure. So blood is flowing into your thorax every time you inspire air. And the deeper you breathe during exercise, the more it sucks blood back to the thorax. And then, of course, it can never go backwards. It just ends up in the heart, stretching out those ventricles. The respiratory pump. Okay, those are things that increase venous return. What about things that decrease venous return? What if the blood volume goes down? If you start to get dehydrated or you have a loss of blood, anything that makes the blood volume go down makes the venous return go down, stroke volume go down. Conversely, if you increase blood volume, you exercise, you have a lot of aldosterone and ADH coming out, and you're actually going to raise the blood volume, and it will stay elevated all the time that you're in an exercise program. And so that will increase venous return. So it could have been put right, oh, it is here, duh, increased blood volume. Okay. A very, very high heart rate will eventually start to impact negatively venous return, because if it's beating so fast, there's just not enough time for blood to fill the ventricle, and so it's not going to get as much blood out if it can't get as much blood in. What's the next variable that affects stroke volume that we're going to talk about? It's called contractility. It's kind of confusing in a way, but contractility is the force of contraction of the heart muscles, the innate force. How strong is it? How hard is it? How vigorously is it going to contract? So we said that kind of depends on preload. So if you imagine not changing the preload and doing something that would change the force of contraction, that's a change in contractility, just to isolate that from preload. So what could cause that? A chemical that steps up the vigor of the heart contractions is called a positive inotrope. So epinephrine and norepinephrine are positive inotropes. They act on the muscle cells They increase the cyclic AMP in those muscle cells, and that's going to lead to more calcium coming into the cytoplasm during every action potential, and we're going to have more cross-bridge cycling and more strength of contraction, and we're going to have increase in stroke volume. Right, another example of a positive inotrope, a little bit the same idea, but a more artificial one. A beta agonist, a drug that binds to the same beta-1 adrenergic receptors in the heart, but it just isn't epinephrine and norepinephrine. For example, isoproterenol. Isoproterenol is a classic beta agonist used to step up the function of the heart clinically in an emergency. So sympathetic nervous system increases stroke volume by increasing contractility. Again, increasing cyclic AMP, increases calcium coming into the cytoplasm and more cross-bridges. All right, here's a little cartoon. We've seen this exact cartoon before, showing the progress, the second messenger signaling that's initiated by the hormones epinephrine and the neurotransmitter norepinephrine. Actually, norepinephrine is also a hormone when it comes from the adrenal medulla. Sorry, my mouthful of ice cubes all of a sudden. Anyway, these catecholamines bind to their beta-1 adrenergic receptor, activate a G protein, which turns on adenylate cyclase, which raises up the level of cyclic AMP in the cytoplasm. That activates a kinase, which will alter the function of primary active transporters that will pump more calcium into the sarcoplasmic reticulum, but also will open up more channels during action potentials on the surface of the cell. Now, this is distinct from skeletal muscle. Cardiac muscle cells have calcium channels on their surface, and if we add some cyclic AMP, more calcium will come in during each cycle. That calcium will in turn be stashed away in the sarcoplasmic reticulum by the more aggressively pumping transporters. And then also, thirdly, we'll have more calcium coming out from the sarcoplasmic reticulum every time the cell membrane depolarizes. So we're going to get more calcium into the cell, store it away in the sarcoplasmic reticulum, and then let more of it out on each beat. And that is how epinephrine and norepinephrine increase the vigor of the contractions. Right, calcium binds to troponin, troponin moves tropomyosin, and the cross-bridge cycling. All right, that was just a little review. I just wrote down what I just was talking about here, so let us proceed. Yeah, so just to remind you, in action potential comes down across the cell membrane, down into the T-tubules, just like on skeletal muscle cells. Changes the conformation of foot proteins in the cell membrane, which changes the conformation of ryanodine receptors, the calcium channels in the sarcoplasmic reticulum. Calcium, therefore, can flood out into the cytoplasm like a flash of lightning. The calcium binds to troponin. Troponin changes conformation and moves to tropomyosin, and now myosin heads that are otherwise blocked at rest can bind to the actin thin filaments and then rotate. Negative inotropes, what would hinder the strength of contraction? Acid. What are some examples? When could there be acid in your blood? How about lactic acid? Too much lactic acid will start to interfere with cardiac function. Right? When you exercise vigorously, producing that speedy fatigue, it's going to not only make your muscles fatigue, it's going to make your heart fatigue a little bit. How about ketoacidosis? If you are diabetic and your diabetes isn't managed sufficiently, right? Your cells can't take up glucose. Your liver starts producing a lot of ketone bodies because of a lot of fatty acid mobilization and oxidation, right? The liver cells are going to produce a lot of acetyl-CoA from chopping up lots of fatty acids coming from the fat during this period of insufficient glucose availability. But those ketone bodies released by the liver are acidic. So you have ketoacidosis, which can very negatively influence your heart's contractility. How about something, potassium? If there's too much extracellular potassium, We need a low potassium outside the cell so we can have a high potassium inside the cell. Where's my hands at? I can't see where they're going to be. And we need a difference. And if you start raising the extracellular potassium, there's not enough of a gradient to cause repolarization of the cells at the end of each action potential, and you're going to weaken the heart function. Beta blockers. We said that beta blockers, a long time ago, this was before Christmas, if you can imagine that. Beta blockers are drugs that really mean beta-1 adrenergic receptor blockers or inhibitors. So beta blockers reduce contractility. They block the receptors that epinephrine and norepinephrine bind to. So we do that on purpose. Sometimes we want to lower the blood pressure by inhibiting heart function. Sometimes we really just want to suppress an arrhythmia, but the result of it is negative inotropy. Finally, the third thing that affects stroke volume, afterload. Afterload is the one most commonly forgotten by people after we have this conversation, then you go back later to try to remember what I talked about. Afterload is arterial blood pressure. It's as simple as that. Arterial blood pressure. The pressure in the aorta, the green line we saw in the diagram, the ventricles cannot eject any blood until the pressure in the ventricle is higher than in the aorta. So if we raise the pressure in the aorta, increase the afterload, the ventricles are going to have to work harder than that, raise the pressure higher than that to get any blood to go out. And so a lot of the heart work is going to be dissipated just trying to raise the pressure. It's not going to eject as much blood. So if we raise the blood pressure in the aorta and all the arteries, systemic arteries, we're going to have a lower stroke volume. The ventricle cannot eject as much blood, and it has to push against a greater force on the other side of that door, on the other side of the aortic valve. So hypertension makes the heart less effective. It's working harder, having to raise the pressure higher, and is getting less done, so it's going to have to do it more often. So we're just going to kill that thing doing hypertension. Emphysema does the similar thing to the right heart, right? Usually when we talk about hypertension, we're talking systemic, we're talking about the left heart. In emphysema, we have a difficulty in pumping the blood through the lungs, the diseased lungs, and so the right heart is going to be faced with hypertension and a struggle to get the blood through there. What's going to happen? The heart's going to be damaged, so we'll see about that at the end of this chapter. So again, here's a picture of the blood in the aorta. Think of it as pressure. It's pushing in every direction on the walls, on this valve. The only way blood can be ejected from the ventricle is if the walls of the ventricle produce enough force, enough pressure to overcome the pressure out here. In order for blood to flow, the pressure here in the ventricle has to be greater than out here in the aorta. Blood flows from high to low pressure, so we have to exceed the aortic pressure or exceed the pulmonary artery pressure before any blood can go out. So if we raise the pressure in these vessels, that's going to make the heart work harder. It's going to, and the stroke volume is going to go down. So here's a summary slide. All the things that affect cardiac output. That's what we're sort of working towards. Exercise. We have increasing sympathetic activity that causes venoconstriction. We have skeletal muscle pumping, respiratory pump, and plus we should mention also if you exercise regularly, increase in blood volume. All of those things increase the venous return. We also have, if we decrease the heart rate, ironically, that increases venous return. Now, overall, that's not going to be a positive effect on cardiac output, but that will increase venous return if we give more time for the ventricle to fill up with blood. If we increase venous return, that's also called, they made these like two separate boxes. Venous return is end diastolic volume and preload. There's synonyms. You make one big green box right here, and if you stretch the wall of that ventricle, if you increase this value, this volume, you'll increase the stroke volume. Frank's Starling law of the heart says that if you increase stretch, you increase force. How about blood-borne epinephrine and norepinephrine? They increase contractility. They're positive inotropes. Thyroxine, thyroid hormone, will also increase contractility because it enhances or accentuates the effects of epinephrine and norepinephrine. It's permissive for those hormones, so it will also, to the degree that there's some of these hormones around, it's going to increase contractility a little bit more. and we'll increase stroke volume. And how do we do that? We decrease end-systolic volume. We decrease the amount of blood left over in the heart because we have ejected more blood. Increase stroke volume. Increases cardiac output. How about the heart rate story? If you activate the sympathetic nervous system due to anger, excitement, anxiety, exercise, increased sympathetic nervous system activity, that drives up the heart rate. If you drive up the heart rate, you have more beats per minute. Each one has its own unique stroke volume. Add them all together, and you get a higher cardiac output until you reach some very, very high heart rate. Your heart rate can't go up over around 200 beats per minute because beyond that, it's not effective at all in increasing cardiac output. It's just making the heart work for nothing. There's not time to fill the heart with more blood if you go any faster than that. So it's designed well. Also, during exercise, you decrease parasympathetic activity, which lowers heart rate, which in fact has tonic activity at rest. Turn off the parasympathetic, turn on the sympathetic, increase heart rate, increase cardiac output. Really important, fundamental, great stuff for understanding the cardiovascular system. A little bit more about heart rate. Again, we've already learned that the parasympathetic nervous system decreases heart rate, and that's true at rest, and that the sympathetic nervous system increases heart rate. There is a mechanism for a negative feedback mechanism for controlling your blood pressure over the short term. It's called the baroreceptor reflex. Let's take a look at that and see what's going on. Baroreceptors are pressure receptors. They're found in your neck and the carotid arteries and in your aortic arch, that part of your aorta, when it rises up from your heart and then swoops down behind your heart. So there's pressure sensors there. If the pressure goes down, that's not good. Because pressure is what moves blood, and if there's pressure that goes down, that means flow is going to go down, and it's not going to be good for your brain. The baroreceptor reflex triggers a reflex increase in heart rate. So that's another major thing that controls heart rate. If you suddenly have some event, such as loss of blood volume for any reason, dehydration, hemorrhage, whatever it might be, your blood pressure is going to go down. If volume goes down, pressure goes down. If that happens, baroreceptors kick in and crank up the heart rate. Chemical mechanisms. Chemicals that affect heart rate. We already said, we're just trying to list them all out. Let's put them all down. Epinephrine, norepinephrine, increase heart rate. Thyroxine, increases the effects of epinephrine, norepinephrine, increases heart rate. Cortisol also increases the effects of epinephrine and norepinephrine, and so it also increases heart rate. Ions, all the ions involved in the action potential, sodium and potassium, calcium, the switch for contraction, if they're not in the right concentrations, it will interfere with heart rate. So we won't get way into memorizing that, just so you know that if there's too little calcium around, we want to depress the heart because there's not enough calcium to be released from the sarcoplasmic reticulum to trigger the cross-bridge cycling. It also affects the SI node. Too much calcium will cause your heart to kind of spasm. Sodium, too much sodium, it will block calcium entry into the cell. And remember, cardiac cells depend on calcium coming in from outside, which they then pump back out at the end of each beat and during each repolarization. Too much potassium, we already said, too much potassium won't let us repolarize the cell. In fact, if the cell's at rest and you just add potassium, the cell will depolarize the more potassium you add, and eventually it will be paralyzed. All right, other factors affecting heart rate, exercise, just because of epinephrine and norepinephrine, right? So that we already kind of knew. Exercise training, though. As you exercise aerobically, right, endurance exercise causes the heart muscle to grow. That's called hypertrophy. The muscle builds in strength and in size, actually, just like other muscles in your body increase in size when you exercise them. And if that's the case, the stroke volume will be more. The muscle is just so much stronger. It pumps more blood out on each beat. And if it's pumping more blood out on each beat, that's going to cause a reflex decrease in heart rate, right? They're going to compensate. Cardiac output is going to exactly match the body's needs. So if one of the cardiac output is stroke volume times heart rate, if one goes up, the other goes down at rest. And so we have the right cardiac output. So people that run a lot have very low stroke or very high stroke volumes, low resting heart rate. I almost stepped on that. body temperature, how interesting is this? If you get a fever, for every degree of increase in body temperature, your heart rate will jump up about 10 beats per minute. It just activates everything faster, and your brainstem is controlling the heart rate, right? The so-called cardioacceleratory center. We'll talk about that next chapter. Age, your heart rate during any particular intensity of exercise will be elevated as you age. In other words, if you're doing the exact same speed of running, you have a higher heart rate with each year of advancing age. Yet, your maximum heart rate will decrease. You guys will have a maximum heart rate around a little less than 200 beats per minute, right around there. My resting heart rate is probably less than 190 beats per minute now, because it's approximately, your max heart rate is approximately 220 minus your age in years. Okay, our last topic for today, congestive heart failure. Kind of a dire thing, and actually a very, very common thing. Congestive heart failure is a condition in which the heart cannot produce enough cardiac output to meet the demands of the tissues. In other words, they're not going to get enough oxygen. When tissues aren't getting enough oxygen, we say they're ischemic. Ischemia. I-S-C-H-E-M-I-A. Ischemia. So that's what heart failure is. Can't produce enough cardiac output to meet the needs of the body. Here's a rule of thumb. Anything that makes the heart work harder all the time will lead to heart failure. It'll kill the heart over the long haul. Or anything that makes the heart kind of hypoxic all the time will eventually kill the heart. When the heart starts to, when I say kill, I mean it's going to get weaker and weaker and weaker at some point later in life. That's what we call heart failure. So what are some common causes of overworking the heart and causing heart failure? Vascular disease, atherosclerosis. What's going on there? Occlusion, meaning blocking of coronary arteries. Atherosclerosis is a diseased state in which plaques build up in the walls of the arteries, narrowing the arteries more and more so that not as much blood can get through there. If the coronary arteries, those are the heart arteries, can't supply enough blood to the myocardium, it becomes ischemic and hypoxic, and eventually, over years and years of time, it starts to weaken. Can't take it anymore. High blood pressure. High blood pressure occurs when you exercise. That's fine. You want high blood pressure then to deliver a ton of extra blood, that cardiac reserve, the cardiac output reserve, and deliver all that extra blood flow to your working muscles. But what happens then? You sit and take a rest. And you rest the majority of your time. You exercise in bouts, we call them. Then you relax. That's good. That trains your heart and grows your heart. If you have something that's causing extra work of your heart all the time, hypertension, chronic hypertension, we're talking all the time, then eventually that will kill your heart. It'll lead to heart failure. So I said the heart has to work harder, raise the pressure higher in the ventricle if you raise the aortic pressure higher and higher to get the blood out. So you just can't eject the blood. At first, if you just raise the blood pressure today to see what would happen, your myocardium would grow stronger, like an exercising muscle of hypertrophy. That means grow larger. Eventually, it will weaken and die, and no one knows the exact reason. You become enlarged and die. How about a history of myocardial infarctions? Not myocardial infarctions, which was what 90% of people will tell me when I ask this question. A history of multiple myocardial infarctions is what I'm talking about, which will lead to heart failure. Why? Every time you have a myocardial infarction, what that means is some part of the heart tissue is going to die from ischemia. Dead heart tissue cannot be replaced. It's non-regenerative. And what happens is fibroblasts are all too ready to come in and create some scar tissue. They'll make a nice patch so your heart wall is intact, but the patches don't contract. Collagen doesn't contract. So if you have multiple heart attacks over years of time, adding scar patches onto there, you have more and more of your heart taken up by inert tissue. The heart gets weaker and weaker, and eventually it's going to start to exhibit heart failure. There's a couple of other things. Some people have a predisposition to the strange anomaly in which challenging your heart, which normally causes hypertrophy, works for them, but then it just goes overboard. And you have overdevelopment of the ventricle, so much so it's almost like one of those stories about a bodybuilder that's his muscles are so big he has no range of motion of his limbs, his joints. Well, a ventricle that gets so thick and so stiff it can't even displace much blood, the stroke volume starts to go down dangerously and you have potentially heart failure. Some risk factors for that, besides just a genetic predisposition: massive alcohol abuse, cocaine, regular cocaine use can cause dilated cardiomyopathy. Catecholamines, too much catecholamines. Certain chemotherapy drugs can damage the heart and cause dilated cardiomyopathy. All right. How about this? This looks like these things are just afterthoughts at the bottom. Valve defects. That's a huge one. If the valves are defective, it's going to force the heart to do more work on every single beat to compensate, and eventually it just can't take it anymore. I'll give you an example. If the mitral valve in your left ventricle, the AV valve, is leaky, so that every time the ventricle contracts, 25% of the blood goes backwards up into the atrium and 75% goes forward. How much output did the body need in blood flow? 100% of what would have been pumped. And so now the heart has to pump harder to produce the right amount of cardiac output, even though a bunch of blood is going back the wrong way. I don't know if that's clear. Anyway, if you have a leaky valve, the heart's going to have to do a lot more work to get the same amount of work done, the same amount of blood out into the arteries. That's one thing, a leaky valve. It could be the aortic valve if it's leaky. Every time the heart rests, blood's flowing back into the ventricle. It's not going around the circulation, it's going back in the ventricle. So an insufficient aortic valve could cause heart failure. How about a stenotic valve? A stenotic aortic valve, that means the valve is stiff, maybe from scarring from an infection or inflammation. It's so stiff and it doesn't open. The leaflets don't flatten out against the sides of the artery when the heart beats. The heart has to pump blood through a narrow opening at very high velocity to get enough blood out. Extra work, heart failure. Usually when we talk about this kind of situation, we're often talking about the left side of the heart, the mitral valve. Like hypertrophy or hypertension causes heart failure on the systemic side. But you can have hypertension in the pulmonary circuit. Emphysema is a degenerative disease of your lungs that will lead to increased resistance in your lungs, hard to get the blood through there. The heart works real hard to do it. The pressure builds up in the pulmonary arteries, and you have pulmonary hypertension. Now the right side of the heart has to work harder to overcome the pressure in the pulmonary trunk. Right heart failure over years of time. So what's going to happen ultimately when someone has congestive heart failure? Eventually, when the left heart, for example, if the left heart gets so weak that it can't keep up, right? The right heart might be fine, pumping blood to the lungs, coming right through the lungs, the right heart's just doing its thing, whistling while it works. But then the left heart, all that blood's coming to the left heart from the lungs, it can't pump it away. It can't keep up. So it pumps some of it away, and some of it kind of backs up into the lungs. As blood backs up or pools in the lungs, the pressure in the lungs, the blood pressure in all the vessels of the lungs starts to rise. And when blood pressure inside of vessels rises, we're getting ahead of ourselves again here, what happens is water begins to leak out of the capillary walls. That's called capillary filtration. So if we raise the pressure in this system, of course we're going to kill the heart over the long term, but at some point there's going to be so much water by capillary filtration leaking into the lungs, into the alveoli, the air sacs of the lungs, it's going to start to interfere with exchange of gases. We're not going to be able to have enough surface area left in there that isn't covered with water to get oxygen into the blood. So now what's going to happen? The blood is going to be hypoxic. If the blood is hypoxic and it goes to the heart myocardium, it's not going to give it enough oxygen. Now the heart's going to get weaker. We already had a weak heart. Now it's even weaker. The left heart. Now we have even more blood pooling or blood damming, it's often called, in the lungs. More capillary filtration. More hypoxic blood or hypoxemic blood. Weaker heart in it, and this runaway drop in blood oxygenation and cardiac function occurs until the person dies. This is usually what eventually will kill somebody with congestive heart failure if something else isn't wrong with them too. They'll have this runaway congestion in the lungs that will eventually drown them, and their heart will just fail utterly and they'll die. Usually we rush them into the hospital, we give them a diuretic, and that causes them to urinate out a whole bunch of blood volume. Reduce the blood volume, will start to take up some of that edema water out of the lungs and so forth. But it's just a battle because now we don't have as much venous return and the heart can't do as much work because there's not enough blood in the ventricle to activate the Frank-Starling law. It's just a battle, and eventually it fails. So on the right side, what are the things that will cause right heart failure? Atherosclerosis, coronary artery disease, same as on the left heart, robs the heart of oxygen, eventually it dies. Pulmonary hypertension, usually due to left heart failure or emphysema. Either one will cause pulmonary hypertension, will eventually kill the right heart. Valve defects on the right side of the heart, same as on the left side if those valves happen to be the ones that are affected, right heart failure. Now, if the right heart fails, instead of having pulmonary congestion, pulmonary edema, edema is what we call it when fluid accumulates in tissues because of capillary filtration. Now we're talking about in the lungs. Come on now. My screen is frozen for some reason. Come on, baby. I don't know what's happening. Anyway, if you have right heart failure, we still have the same kind of effect. We have blood damming, blood pooling, blood backing up, but blood is backing up into the systemic circulation. So people with right heart failure they'll be all puffy and doughy looking on their skin. In fact, if you take your finger and point into the skin, it'll stay dimpled down like an unfinished cake baking, because it's just water filling up the tissues called edema, and when you push down, you'll push away some of the water and it won't spring back because it's not elastic. Anyway, that's what's called pulmonary edema. So that's the end of our story. End of chapter 18 for us. We're not going to talk about the developmental aspects of the heart, but I hope you enjoyed talking about the heart. It's fascinating. There's a ton of healthcare burden in this country and all over the world associated with failure of the heart and difficulties with the heart and understanding the heart, managing the functions of the heart. So it's a great chapter, and it will lead us right into chapter 19, in which we'll learn about the whole cardiovascular system. We'll put it all together, the blood, the heart, and the blood vessels, and all the systems that impact them regulatorily. Okay, see you next time.